So my name is Karen Sapuka, and I'm the director of the Health Decision Sciences Center at Massachusetts General Hospital and an assistant professor of medicine at Harvard Medical School. I have no disclosures to report. So today I'm going to be talking to you about shared decision-making around decisions about breast cancer screening for women aged 40 to 49. So in the webinar, we're going to start by reviewing clinical guidelines from several national U.S. organizations. We'll review risk factors associated with breast cancer and some tools you can use to estimate a woman's risk of developing breast cancer. We'll talk about some of the evidence for the benefits and harms of cancer screening, focused on women aged 40 to 49. And then we'll discuss some strategies to elicit patients' goals and preferences, and how to do that in the context of a short clinic visit. Finally, we'll point you to some tools and resources that you'll be able to use to help promote shared decision-making conversations and practice with your patients. So several national groups have guidelines with respect to breast cancer screening. And in the past, there's been certainly some controversy in these guidelines. But as you'll see, the recommendations are becoming more aligned over time. So we'll start with the United States Preventative Services Task Force. They updated their guidelines in 2016. And for women who are asymptomatic, who are at average risk for developing breast cancer, they recommend that doctors make an individual decision with these women. And what that means is that they recommend that doctors are taking into consideration clinical factors as well as patients' values and preferences. Some women who place a higher value on the benefits in terms of the reduction in mortality may decide to start screening at age 40. Others, who are a little more worried or concerned about some of the potential harms of screening, like the increased rates of false positives, may decide to start screening at age 50. Since patients feel differently about these outcomes, that's why they've decided to actually make this an individual decision. And this is a C recommendation, which means there's at least moderate certainty that the net benefit is small. It doesn't mean doctors should encourage or discourage women from getting screening, but it means that we need to provide it to selected patients based on these clinical considerations and based on patients' preferences. So at the other end of the spectrum for guidelines comes from the American College of Radiology and the Society for Breast Imaging. And their guideline recommends annual screening for average risk women beginning at age 40. The American Cancer Society sort of splits the difference between these two. So they recommend an individual decision for women aged 40 to 44, and then they recommend annual screening for women aged 45 to 54. And these organizations all, value, I think, the small reduction in breast cancer mortality, but also recognize some of the harms. So this table just summarizes some of the recommendations from these leading organizations. And as you can see, several of these organizations have fairly consistent support for the use of shared decision-making to help decide whether or not to start screening at age 40 or screening at age 50. So shared decision-making is a common theme in many of these guidelines. So how do we have a shared decision-making conversation with our patients? Definitions of shared decision-making can vary, but the one that I like really focuses on this as an interactive process between patients and clinicians. And it's really focusing on having a good conversation with our patients. Often this requires inviting our patients to participate and engaging them in the decision-making process. Some may be expecting you to tell them what to do, but once they understand and learn a little bit more about the situation and their options, many patients and most patients are usually very excited and interested in becoming involved in that process. At the core, we're also shared decision-making is about providing accurate information and evidence about the options and the benefits and harms of those options. And then really tailoring the treatments or the tests in this situation to patients' goals and preferences, what matters most to them. And the reason we think shared decision-making is such a good thing is because it's one real way to improve the quality of decisions, to make sure our patients are well informed, that they're meaningfully engaged, and that they're receiving their preferred option. So to help illustrate how you might apply shared decision-making to the situation for breast cancer screening, I'm going to talk through two cases. And these are two primary care patients who came to see a physician at MGH, actually during the same week last year. And they have some very similarities, but as we'll see, their cases do differ in some certain situations. So Mrs. T is 41 years old. She has 2 kids, relatively healthy, not on any medications, and she's got no family history of breast cancer. She's had no biopsies or any prior screening. Mrs. M is 42 years old, also has 2 children, relatively healthy, no medications, and her mother was recently diagnosed in the past year with breast cancer. So if these women were coming in to see you for an annual visit, how might you approach the conversation with them? It would be very reasonable to discuss breast cancer screening with both of these women. And how would you do that? So if we're having a shared decision-making conversation, what are some of the things we might review or discuss? So first, what's the chance of being diagnosed or dying with breast cancer? How do these women's risks vary? Are they the same? Are they high risk? Are they low risk? What options might you offer in terms of breast cancer screening? What would you tell them about the expected benefits and harms? What might they expect from either starting or not starting screening? How would you assess their preferences and goals? How would you know what's most important to them? And then would you make a recommendation, and if so, what might you recommend? So we'll talk throughout the rest of this webinar to give you some information to answer some of these questions and have these kinds of conversations. Now, these guidelines are for women who are at average risk. So how would we know if these are appropriate and if women are at average risk for cancer? You're probably aware of the many different risk factors for breast cancer. There are some that are fixed and others that are modifiable. Age and gender are 2 of the main risk factors for developing breast cancer, but family history, genetics play a large role for many women. A first-degree relative, having a first-degree family relative, a mother, a sister, or a daughter with breast cancer, has about a 2-fold increase into the breast cancer risk. Breast density is another common risk factor. Studies suggest that somewhere around 43% of women aged 40 to 74 in the US have dense breasts, either heterogeneously or extremely dense breasts. And having dense breasts has about a 3 to 5-fold increase in the breast cancer risk. Although it's important to note that breast density, although it's been associated with a higher chance of developing breast cancer, it hasn't been associated yet with a higher chance of dying from breast cancer. So radiation exposure, women who've had prior radiation treatment, for example, for Hodgkin's lymphoma, when they were younger, are also at a higher risk for developing breast cancer. Race and ethnicity and reproductive factors are also can increase risk. So there are several models available that can help you develop an estimate for your patient's risk of developing breast cancer. One that is often used is developed at the National Cancer Institute, and it's their breast cancer risk assessment tool. It's based on the Gale model, and it's available online here, and we have it on the resources page as well. So the model takes several different pieces of information, reproductive factors, family history, age, and develops a 5-year and lifetime estimate of breast cancer risk. It's most appropriate for women without a strong family history, and we'll point you to some resources for any women that you're working with who may have a stronger family history. So let's look back at Mrs. T and Mrs. M. So we plugged their information into the Gale model, and here's what came out for their 5-year and lifetime risk. So as you can see, the main difference between the 2 of them is that family history, and it's about a 2-fold difference in their 5-year risk. So as we mentioned earlier, these guidelines really are for average risk women, and so if we're worried about someone who might be at high risk, there are other screens that we might go through. There aren't strict cutoffs, but generally folks look at a lifetime risk of 20% of developing breast cancer and use that as sort of a threshold for identifying folks who are at higher risk, who might consider either genetic counseling, high-risk programs thinking about prevention or additional screening. So both of the women actually will go through and actually met our shared decision-making average risk because they didn't hit that 20% lifetime risk, so it would be appropriate for doing shared decision-making. So for both of these women, the questions will be, when should we start? What age do we want to start screening? And then how often should we be screening? Now, there's no magic to the number 40 or the age 50. These have just been chosen, I think, because they're generally round numbers. There's a bit of a false sort of dichotomy there. The idea that screening provides relatively more benefit as women get older and relatively fewer harms as women get older, makes it reasonable to potentially start screening anywhere between age 40 and 50, depending on what makes sense for the individual. But for the purposes in the evidence that we're going to show you, we'll just assume that there's a starting age at 40 and a starting age at 50 and see how that compares for the evidence, for the benefits and harms of screening. Now, there are multiple methods for screening. The most common is mammography. Now, historically, screening film mammography is what's been used. But for the most part now in the US, digital mammography is what's being used, and that's sort of available immediately on a computer for review. Computer-aided detection is then able to be used on those digital mammograms to try and find and spot lesions that the radiologist might miss. Digital breast tomosynthesis is a new technique. It has been, basically it's a 3D view of the breast. It's been FDA approved, and it's increasingly common, but by no means widespread. The radiation dose is about equivalent to that of a regular mammogram, digital mammogram. Now, the United States Preventative Services Task Force has reviewed the evidence for DBT and has actually concluded that there's insufficient evidence to assess the benefits and harms. So they've made no recommendation, certainly about using it exclusively to screen for breast cancer. So ideally, this is probably going to be changing in the future as we get more evidence on this screening modality. But for now, it hasn't been recommended to be used as the sole method for screening. So using MRI or ultrasound in addition to mammography is also used, certainly for women at higher risk and for women with symptoms. But again, for right now, these are not actually recommended for women who are at average risk and as additional to screen. Folks have been interested to try and figure out what to do with women with dense breasts, and are there other screening or additional screenings to be used for women with dense breasts. But again, the United States Preventative Services Task Force has reviewed evidence around the use of MRI and ultrasound for women with dense breasts, and has also found there's insufficient evidence to say that it actually helps. So they've made no recommendation for that either. So we're going to be focusing mainly on data around the use of mammography for screening. So let's go through some of the benefits and the harms of screening. So there's considerable evidence from randomized control trials and from observational studies that have been conducted in the US and abroad to help us understand and refine estimates for the benefits and harms of screening. So meta-analyses really demonstrate about a 20% reduction in breast cancer mortality for screening. Now, this is slightly smaller for younger women, about 15% for younger women, and it's higher for older women, about 32%. However, the data have several limitations that are important to note. First, the trials may underestimate the mortality benefit, and this is sort of due to two different reasons. One is due to contamination. So women who were randomly assigned to no screening, many women in those arms ended up having a mammogram over the course of the trial and follow-up period. And also, the women who were randomly assigned to the screening arms had less than 100% adherence to the screening intervals that were recommended for that arm. And so we might be underestimating some of the potential mortality benefit. All the trials are quite old at this point. I mean, we want long-term follow-up data to understand the impact that these screening modalities are going to have on the diagnosis and treatment and survival from breast cancer. But that means that these women mostly were enrolled over 25 years ago, when the techniques for mammography were different, older techniques which were less sensitive. So using today's techniques, we might actually pick up and detect more cancers earlier. However, the treatments were also less effective that women were getting. So it's also possible that women who are getting diagnosed now will have much more effective treatment, so even if it's not diagnosed earlier, would do better. And then researchers have studied and tried to look at what might be contributing to declines in breast cancer mortality, and for the most part have estimated that the contemporary treatments, so the extra and the beneficial treatments, are accounting for most of that decline, more so than screening. There's also new concerns in the recent years about this concept of overdiagnosis and overtreatment. So the idea that we might be, through screening, finding things that never would have caused any problems. And once you find something, there's a lot of need to treat it. It's hard to just leave it alone. And so there's lots of concern about overdiagnosis and overtreatment. However, there is no consensus on how to measure this or even how to define it. And so we have very wide estimates and a lot of uncertainty around our estimates for this potential harm of screening. So taking all of that, there have been several researchers who have developed pretty sophisticated computer models to try and mitigate some of the limitations of the randomized controlled trials and the observational study evidence, but also allow us to do some comparative modeling to figure out, well, what would be the difference if we started earlier or started at different ages or screened people at different intervals annually versus biannually. And so these are the estimates taken from those computer comparative effectiveness models and form the basis for the recommendations from the USPSTF. So this is tracking 1,000 women who undergo biennial screening, and it's comparing women who started at age 40 and then screened through age 74, comparing what they might expect to someone who started at age 50 and then screened through age 74. And so if we look at the difference between these two, that's what's going to help us understand what's the potential benefit and the potential harm of screening. So potential benefit, about 1 breast cancer death will be prevented. So for every 1,000 women who start screening at age 40, we'll prevent potentially 1 extra breast cancer death. Now, I rounded these numbers. So the cost of that 1 breast cancer death prevented is about 600 additional tests. So false positives requiring additional testing. About 70 of those will actually get to the point where they need a biopsy to do that testing. And according to their estimates, about 2 overdiagnoses. So how might you communicate that to your patients and sort of crystallize that information in your conversation with patients? There's certainly reasons to start screening at age 40. The main one is to lower your chance of dying of breast cancer. And you will have a small reduction, but there is certainly a reduction there that might be very meaningful for many women, about 1 in 1,000. It may catch cancer earlier when it's easier to treat. And some women may have peace of mind from these negative results, so getting screened earlier. There's certainly some reasons to start at 50. Most of your lifetime benefit you're going to get from screening between 50 and 74. So 7 of 8 of those breast cancer deaths averted, you'll be able to pick up. You're going to have a much lower chance of having a false positive that requires extra testing and may cause extra worry or anxiety. You're going to have a lower chance that you'll find and treat a cancer that would never have caused any problems. So you'll be avoiding some false positives and avoiding some of that overdiagnosis. Now, if someone's leaning towards screening, there's sort of a reasonable question to ask, should I just do it every year or should I do it every other year? And here are some of the key points about that. The reason to screen annually, if that mortality benefit is really what's driving your decision, you're going to get a little bit more mortality benefit if you screen every year. But at the cost of having actually more false positives, more additional tests, more biopsies. That sort of might help someone thinking about if they're very interested in screening, want to start at 40, it may be very reasonable for them to screen every year. If they're hesitant and worried about the false positives, or maybe they're sort of weighing it back and forth, maybe screening biannually every other year might be a great option. So it's a lot of information to convey to patients. I think you've heard about decision aids and other tools that can help communicate that information. These are just a screenshot from, I'll show you a screenshot from 2 different kinds of decision aid tools that use graphics to convey the numbers. And the nice thing about either these bar charts or a pictograph that I'll show is it conveys both the number who might die of breast cancer, the number who won't be dying of breast cancer, and then if you compare these, you'll see that there's only one difference. One of the challenges, obviously, with breast cancer screening and any screening is the benefit really is potentially fairly small when you look at it from an individual perspective, and that's certainly what is showing from these. You can kind of barely see the difference. But for many women, that's still an important benefit. And this is just a pictograph, so it's got 1,000 little dots. 4 of them are blue for people who start screening at age 50, and 5 for people who start screening at age 40. So now let's talk about some strategies to elicit patients' goals and preference. So you've discussed a little bit about the information, you've given them some options, and now it's time to figure out, well, how do you feel about this and what's most important to you? Now, some patients, can start and have these conversations very easily. They'll be, talking away. Others, it may be more, we need a little more help to figure out what's important to them and how they're feeling about these things. And here are a couple of questions that can be helpful to start the conversation and to help them reflect on how they are feeling about these things and help you get a sense for what might be most important to them and which option they might be leaning towards. So how worried are you, asking your patients, how worried are you about dying of breast cancer? Is it something you've been thinking about? Is it something you've never really thought about? And obviously people who are more worried about it may be more interested in getting that survival benefit. How important is it to you to find and treat breast cancer early? Is that something that you're really motivated to do? How worried would you be if you got called back for additional tests or treatments? Is it something that wouldn't be a big deal, or something that you'd have some sleepless nights waiting up and have a lot of anxiety on? And so this can help you get a little bit of a sense for where someone might be leaning. Now, some of your patients might come in and actually have a clear preference. Of course, I want to start screening, and that's great. It's always nice when patients have thought about things and come in with a preference. But to really meet the the different elements and the different key points of shared decision-making, you'd want to do a little bit to make sure that that preference is well-informed and that that's pretty strong preference. So you'd want to check their understanding of the benefits and harms. And you might ask them to just say, well, tell me a little bit about what you hope to achieve by screening or starting screening at age 40. Anything you'd be worried about screening. And just to make sure that they have a really accurate understanding. Someone who says, I don't want to get diagnosed with breast cancer. It's going to prevent breast cancer for me. You might need to stop and say, okay, we got to talk a little bit about what screening is going to do for you. We're actually more likely to diagnose you with breast cancer if we start screening. But we hope we'll find it and treat it earlier. And then if they have a good understanding of the benefits and harms, then you can focus on some issues around supporting them to implement the decision, making sure there aren't any issues with cost or transportation or any other things that might get in the way of them actually implementing their decision. Other patients may come to you and say, I'd rather wait. Doesn't sound that great. Maybe this isn't such a good thing. Can I just avoid this and start later? And that's great too. But again, here, I think you're going to want to check their understanding, make sure that this is really an informed preference. And I know from talking and doing work with our primary care physicians, some of them are a little more hesitant to not start screening with their patients. And so if a patient does come in and say, I don't want to wait till I'm 50, they want a little more, assurance that this patient really is okay with that, and that if they find something, that's not going to come back and bite them later. And so we've worked to try and crystallize some ways to really explore the strength of preference, particularly for folks who want to delay the screening. And here's what we've done. We've sort of set up this scenario, and we have our physicians ask patients this scenario. So let's say we decide not to start screening until you're 50, and it's 4 years from now, and we found a lump, and it turns out to be cancer. We can treat it. It's not going to impact your mortality. But how would you feel about that? Would you be kicking yourself that you didn't have that mammogram sooner? Or would you be grateful you had 4 years of not knowing and not worrying about it? And we've had feedback from our physicians who have asked patients this question, and it might take them a few seconds to sort of sort through this in their head and give them a little bit of time to think through it. But people can kind of sift themselves into those two buckets. And obviously the person in the bucket of kicking themselves, those are the ones that are going to be subject to a little more regret. And maybe, you might want to push them to start screening a little earlier. People who are going to be grateful for having 4 years of not knowing and not having to worry about it would be fantastic to wait for screening, because for them that false positive is probably going to be a lot worse than the potential small benefit. So let's get back to our 2 patient cases for Mrs. M and Mrs. T. Now, when we had our PCP telling us the story of these 2 patients, she had a pretty clear prediction that, I totally thought Mrs. T was going to want to start at 50. She's, healthy, but tends to not really want to do too much medical things if she can avoid them. So she really thought that, if she was diagnosing this patient's preferences for screening, she would have thought that she was going to come in and not start till she was 50. And for Mrs. M, on the other hand, whose mother was just diagnosed, she was pretty sure she was coming in and going to want to ask, can I get my mammograms today or tomorrow? Really want to start screening now because of this new family history. But during the conversation, both women were sort of leaning towards not screening. And so the physician actually asked them that question just to make sure and see if she could really make sure their preferences were strong to stop screening. And when she asked them, what she found was that Mrs. T, after thinking about it, would say, I'm going to kick myself if that happens. If I haven't done everything I could do, I think I really would kick myself. Whereas Mrs. M was very clear and confident that she would be happy and grateful to have had 4 years of not knowing and not worrying about it. So, based on this, what happened was Mrs. M actually did start screening. They started biennial screening. Mrs. T started screening with biennial screening, and Mrs. M decided to delay screening. They're going to revisit it when she turns 45, but right now the plan is to start screening when she turns 50. So just to sum up, when we're making the decision, you want patients to be well-informed and have a clear preference, and that's fantastic. Then we really work on supporting implementation for shared decision-making. You might, despite your best efforts in communicating this information, even giving decision aids, people still might come in and not really have a clear preference or be kind of on the fence and want to defer to your recommendation, and that's okay. If you have their answers to some of these questions about their preferences and goals and what makes sense to them, then providing that role of putting that together into a recommendation. Because I hear you say you're worried about this, this, and this, I really think we should start screening now. Or alternatively, because I heard you saying you're really worried about that false positive, you think you're going to be very anxious, I think we should wait and just start screening when you're 50. So, playing the role of sort of facilitating that and making a recommendation that really is individualized and based on their goals and concerns can be very helpful in moving things along. And then as we have seen, there's no rush here. There's no urgency to make this decision right away. We can delay the decision. Patients can get more information. They can discuss this with their spouse or others. They can think through some of these questions that they maybe have never even thought about before and clarify their preference, and you can just plan to follow up at another visit or even next year. So just to wrap up, we'll talk about some tools and resources. Just want to point to or make sure you look at the resource page associated with the webinar. It has really great information, a decision aid on mammography, links to other online decision aids, links to the Gale model that you saw earlier, as well as other breast cancer risk calculators, and then links to some tools for assessing genetic risk for breast cancer for women who might have more extensive family history and you're wondering whether or not it makes sense to get them referral to genetic counseling. So just in summary, most guidelines do emphasize shared decision-making for discussions about breast cancer screening for women aged 40 to 49. Starting at screening is going to provide a small improvement in breast cancer-specific mortality at the cost of more false positives and a small potential for overtreatment. Decision aids and other tools can really help communicate the evidence for the benefits and harms and how women feel about their individual breast cancer risk, and the potential benefits and harms really should be guiding these decisions. And making sure we give them the opportunity to have that discussion, because sometimes the way assumptions that we make or what we think is going to happen is not always what they want. And that's it. Thank you.